Hi, I'm Fatthi Abdel, Professor of ENT, Alexandria Faculty of Medicine, and in this video I'm going to discuss the different sequences of MRI in the inner ear and brain. There are two main basic sequences for the MRI in brain, the T1 and the T2. For those who are not acquainted with MRI brain, we are usually looking for the outer gray matter, the inner deep white matter, and the CSF in the ventricle. For T1, the outer gray matter will look gray and the deep white matter will look white. What we observe here that the color is the same as anatomical name. The CSF is black because T1 is not fluid sensitive. The reverse is true in T2. In T2, the outer gray matter is white and not gray, and the inner white matter is black and not white. So in T2, the color is the reverse of the anatomical name. However, the CSF will look white. Why? Because T2 is fluid sensitive. So the main differences at the brain section that in T1 the black CSF is surrounded by white area, whereas in T2 the white CSF is surrounded by black area. If we go down looking for the cochlea, we have to look for the T2 because the cochlea is filled with fluid and T2 is fluid sensitive. So the cochlea will appear in T2 and will not appear in T1. So in T2 you will see the cochlea as a white area. To know that this is T2 also, you look for the CSF in the ventricle and in the cisterns, you will find them white. And you look for the eye globe, you find it white. So in T2, all are white. Whereas in T1, as we mentioned, cochlea will not be apparent. To be sure that this is a T1, again, the fluid of the CSF is black and the eye globe is black. What are the other sequences different from T1 and T2? We have the T2 heavily weighted images, and this has different name depending on the company, sometimes called Fiesta, sometimes called 3D flare. The T2 heavily weighted, it's a T2 but exaggerated, so it will better delineate the cochlea, so it is better for us. So if we are going to request for cochlear implant, we will ask for T2 heavily weighted image. If you want to know the size of the cochlear nerve, you request for the T2 oblique parasagittal reformatted image. If you suspect a cholesteatoma, you are going to ask diffusion image. For example, the patient will have a cholesteatoma, you have removed the cholesteatoma and you want to go for CI, you want to check that there is no residual, you have to request diffusion image. If there is a symmetrical hearing loss or anything denoting a suspected mass lesion in the internal auditory canal or in the cochlea, we go for T1 with gadolinium. And if you suspect multiple sclerosis or brain lesion, you have to have a flare. We will have a separate video for the heavily weighted T2 images explaining the cochlea, coronal and axial view, the normal anatomical part. But now we are going to discuss the other sequences. The first one is the parasagittal reformatted. When you are in the parasagittal, in the multiplanar reconstruction mode, you look in your screen, you will find three different sections. One axial, one coronal, one sagittal. We usually go for the sagittal. We draw a line parallel to the internal auditory canal. And then we draw a line perpendicular to the line parallel to the internal auditory canal. So a line which will be perpendicular to the internal auditory canal. Then we are going to move this line, which is perpendicular to the internal auditory canal, to 3 different levels. And at each different level, we have to watch it in the sagittal view. So now we are in the axial view, but when we look for the nerve, we are going to look it in the sagittal section. If you are at the CP angle, you will have this picture. You will have a facial nerve and vestibulocochlear nerve. The vestibulocochlear nerve is not yet divided. If we move laterally and we go for the porus acousticus, you will have 3 nerves instead of 2. The facial nerve and the vestibulocochlear now is divided into cochlear and vestibular. If we move more lateral and you go to the middle of the internal auditory canal, you will have the 4 nerves, the facial nerve, the cochlear nerve, and the 2 divisions of the vestibular nerve, the superior and inferior. And this is usually the main target to see in our cochlear implant request. What we look for in this parasagittary formatted sequence, we usually look for the cochlear nerve, if it's present or not. And if it's present, what is its size? So usually to know the size, we compare it to the facial nerve. It should be greater or at least the same, equal as the facial nerve. If it's smaller, this is a hypoplastic cochlear nerve. And if the 2 cranial nerves are hypoplastic, you compare them to each other. And if you are going to operate, you are going to operate the more formed cochlear nerve. If you don't find a cochlear nerve at the middle of the internal auditory canal, you go to the CP angle to see if it's only the facial nerve which is there, or there is a facial nerve and a vestibular or a vestibulocochlear bundle, which will be a better prognosis than if it's only the facial nerve. The diffusion images, as we mentioned, these are done when you suspect cholesteatoma or you are going to operate a case of operated cholesteatoma. And the cholesteatoma in the diffusion weighted images, it will restrict diffusion and it will appear as white. And when we see this white area of restricted diffusion, we are suspecting cholesteatoma. Until recently, we were saying if you find this restricted diffusion area, wide restricted diffusion area, we were confident that it is cholesteatoma. But now we realize that there are false positives, and to be sure, we have to go for what is called the ADC map. And in the ADC map, the area of restricted diffusions will turn to black. It will not be white, it will be black. So if in the diffusion weighted it's white and it's turned black into the ADC, this is a confirmed cholesteatoma. But if the white area in diffusion weighted image remains white in the ADC map, this is what we will call the T2 shines through, and we don't have to go into the detail of this finding. T1 with gadolinium. As we mentioned, to see the cochlea and the cochlear nerve, it's better to go for T2. Here on the normal side, on the left side, you can see the cochlea, you can see the cochlear nerve, you can see the semicircular canal, the lateral semicircular canals, the vestibule. On the opposite side, what do you notice here? You notice that the internal auditory canal is dilated on the right side. It's hyper-intense. You are suspecting intracanalular mass lesions. You look for the T1 with gadolinium. Why we say that this is T1 with gadolinium? We say T1 because the eye globe is black, because the CSF in the ventricle is black. Why we say gadolinium? Because the sigmoid sinus is hyper-intense here. So there is enhancement of the blood. What do you notice in this picture? You can see that on the left side, on the normal side, there is no enhancing lesion, whereas on the right side, there is an internal auditory canal lesion which is enhancing, and it should be, as we know in T1, there should be no cochlear nerve, no nerves that can be seen. So if you see this lesion, this is an enhancing lesion, and this is an intracanalular lesion. Another example. On the first picture, the T2 heavily weighted images, again, the normal side, the left side, there is a cochlea seen, white cochlea is seen. Whereas on the right side, there is no such cochlea. There is a filling defect. So you are suspecting a lesion in the cochlea. We go for the T1 with gadolinium. What we find in the T1 with gadolinium, on the left side, there is no mass or no lesions on the left side. Whereas on the right side, there is an enhancing lesions which looks white. So this is proved to be a very early cochlear schwannoma. The T2 flare. To revise the sequences again, T1, you can find that the CSF, black CSF, is surrounded by white. T2, the white CSF is surrounded by black. The T2 flare is a T2, but the fluid was attenuated, hence the name flare, fluid attenuated. So the CSF will be black, but still the white matter will be black. So if I give you a moment for the three pictures, in T1, black surrounded by white, in T2, white surrounded by black, and in T2 flare, black surrounded by black. An imaging algorithm. If CSF white, this is definite T2. If CSF black, you look for the white matter. If it retains the name of the anatomical name, the white is white, this is T1. If it is not retaining the name, the matter is black, this is a T2 flare. The importance of T2 flare mainly is in the periventricular white matter lesion, where you can appreciate the white matter lesions because you attenuated the fluid in the CSF, the white fluid in the CSF. Because in T2, like this one, I think it's very difficult to appreciate this lesion to get it from the background of the white CSF in the ventricle. In summary, for cochlear implant, the main sequences are the heavily weighted T2 images, to see the cochlea and its patency, the oblique parasagittal reformatted images to see the cochlear nerve and its size. There are other sequences which are depending on your suspicious. If you suspect a mass lesion, you do T1 with gadolinium. If you suspect cholecystoma, we do diffusion images. And if you suspect a flare MS or multiple sclerosis, we do flare technique. I would like to thank you, and I hope to see you in another presentation.